Hi, this is Michael Monheit, and I'm here with co-counsel and my friend for over 20 years, Rob Jenner. And we're here to talk about the litigation against Gilead for a drug called tenofovir disoproxil fumarate, also goes by the name TDF. Rob, why don't you tell us a little bit about the history of this drug?
Sure. The drug was first invented in Belgium, actually. It was founded there, and the scientists were working on it knew that they had come across something pretty important. It was a very powerful antiviral agent, and the drug eventually made its way over to the United States, where some scientists picked it up and started working on it. What they found, however, is that the drug, while effective, could only be effective if it was administered intravenously. And so they were making progress with the drug, but they realized they couldn't make it a consumer product to the extent that somebody needed to get a shot every day intravenously. So they continue to work on it to see if they can get it administered in another form.
So they're trying to find a way to make it like bioavailable within the body so the body could absorb the medication.
Exactly. The concept of bioavailability, as you say, is exactly that. How does the body use a medicine? How does it absorb it inside the cells to make it effective? And the concept of bioavailability was what the scientists here in the United States were trying to work on to make TDF something that could be useful.
Now, I've heard this drug referred to as a prodrug. Could you tell us a little bit about what a prodrug is?
Sure. A prodrug is a drug that does not work until it's metabolized in the body. It's sort of like what is the delivery mechanism that can be useful to help break down the drug. Although it's not really an accurate analogy, I sort of try to think of it like NyQuil or a cold medicine. The underlying medication is the same, but you can take it in a pill form, in a capsule form, in a liquid form, and it all will hit you differently over a different period of time. It's not exactly the same, but the concept is useful to help me at least understand exactly what we mean by bioavailability.
So they took the base drug tenofovir and they combined it with other elements, other chemistry to make it available in the body?
It wasn't so much combining with other elements. It was just a way to manipulate the chemistry of it so that it can be delivered in certain ways.
Rob, what is the difference between TDF and TAF?
Sure. TDF, as you said before, is tenofovir disoproxil fumarate, TDF, and TAF is tenofovir alafenamide fumarate, TAF, also known as we spell it out, the TAF drugs. One of the ways that I like to think of it is that the TDF drugs get the letter grade D, dangerous, and the TAF drugs get the letter A. So you always want to get the A over the D, and that's how at least I help differentiate the two in my mind.
What are some of the injuries that we're seeing as a result of people taking TDF as opposed to being on TAF?
The TDF drugs have been shown, and the studies have been conducted by Gilead themselves, to be much more dangerous, much more injurious to the kidneys, to the bone, and to your teeth. And the studies, head-to-head studies, comparing TDF and TAF have been remarkable in that they have shown the overall efficacy of TAF as superior. In other words, it's a better antiviral agent. It suppresses the virus better. It increases the white blood cells, which you need to help fight infection, known as the CD4 cells. And it's also safer, both to the bones and to the kidneys. In fact, there is a study coming out very shortly in the International Journal of Infectious Diseases. The article reviews 8 head-to-head randomly controlled trials that compared the TDF and TAF drugs. The conclusion of that article reads, virologically suppressed HIV patients on TDF-containing regimens significantly benefit from switching to TAF-containing regimens, resulting in better viral suppression, better immune reconstruction, and less bone and renal problems. What we're seeing here is not some lawyer-created theory of what may happen. This is science that you can get off of the off of Medscape and other scientific libraries and scientific journals. Many of the authors on these studies are, in fact, Gilead scientists, and it's just remarkable how much better TAF is than the TDF drugs as reported in the scientific literature.
And you suggested people would go look at the International Journal of Infectious Diseases. That's what they would search for that study.
For that particular study, correct.
Let's talk about the different types of injuries. What are the injuries that were being caused to the kidney?
Sure. What we're seeing is full-blown kidney failure. We're seeing kidney dysfunction. We're seeing the entire spectrum of kidney injury.
I noticed that some people that have contacted us have complained of having cysts or nodules on their kidneys. Is that related to this, or is that unrelated?
It depends. All because you have a cyst on your kidney doesn't mean that it's caused by a drug. Now, a cyst can be a precursor to a problem coming on, but that's really for a doctor to diagnose an individual patient rather than there being a blanket statement that all cysts are a result of TDF-induced kidney damage.
Now, of course, as you're keen to remind me, we're not doctors.
We are not doctors. We don't play them on TV. Our audience here, we hope, understands that we are not making any recommendations on what tests should be done or what may or may not be caused. The information we're talking about is information that our experts have explained to us or what we've read in the scientific literature. But certainly if an individual patient has a question about what his or her condition is or what he or she should be doing for the condition, that's solely a conversation that should be had between the patient and the physician, and nothing that we say here should have any influence over that.
Now, some people may have their doctors decide to run tests, maybe to check their creatine levels or the flow rate of their kidney. Tell me a little bit about those tests. And again, not as a doctor, but from what we've learned so far.
We've spoken with some very highly credentialed doctors around the country, doctors who specialize in kidney loss and bone loss. And what they have told us is that when they're approached by somebody who may have a kidney problem, these are some of the tests that they run for some of their clients, again, or some of their patients. And not every test is appropriate for every patient. That's why you need to speak with your physician to see whether a particular test may be right for you, not to sound like a TV commercial. But here are some of the tests that our doctors have talked about. When you want to diagnose a kidney problem, you can look for what's called the GFR, the glomerular filtration rate, easily said as a GFR, and that will measure your kidney function. The problem, Mike, with having kidney disease is that a lot of it can be subclinical, which means you may not have any outward symptoms of kidney disease, and your kidneys may in fact be injured. The kidney is a pretty robust organ, and it can work with a small percent still functioning.
So somebody might be told by their doctor their kidneys are functioning at 60%, and they might not have even known that they were having a problem, even though the kidneys aren't fully functioning.
That's exactly correct. And so doctors will run the GFR test to give them an indication as to whether or not any injury has been done. And so it's an important test for doctors to run on some patients.
What about the creatine?
Sure. There's serum creatine level is something that can be tested in the blood, and it's a measure of proteins that have been released if the kidney has been injured. So you can do it all in one, one panel, one blood panel. But the GFR test, serum creatine level, all are things that can be evaluated and give insight as to how your kidneys are doing.
Have any patients had kidney failure to the point that they had to receive dialysis or had to receive a transplant as a result of this medication?
Absolutely. The thing that's interesting is, these are antiviral medications. If they're working, the virus should not be progressing, and your kidneys should be fine. All right, that's the whole point of being on these medications. But if in fact the medication itself is gumming up the tubules in the kidneys such that the exchange of toxins can't be released, which is what the kidney does. It's a big filter. If it can't release the toxins and the toxins build up, that's when you can get kidney death, and that's how the problem occurs. So an effective drug will stop the virus from attacking the kidney, and an effective drug will not hurt the kidney in and of itself.
The kidney's trying to clean the body, and here's a drug that you would hope is going to be helping the kidney, but in fact it's doing the opposite.
Exactly.
And what sort of injuries occurred to the bones and the skeletal system?
The kidneys and bones are related, having to do with a very complex biological mechanism. In a very easy sense, you need vitamin D for your bones. When the kidneys aren't working, it affects the vitamin D output. And so the vitamin D is being sucked out of the bones, making them brittle. That's a very simplistic explanation, but it's related. And so you need healthy kidneys for healthy bones. That's why teeth are impacted as well, because the teeth are full of calcium, and the calcium is being sucked out of your teeth. And so many of our patients are losing their teeth, which is a problem we can discuss a little bit later. But in and of itself, losing teeth is a problem for the entire body. So what our doctors are telling us when we have potential for bone injury, the doctors are running what's called a bone mineral density test, also known as a DEXA scan, DXA, which will give us a T-score, which is an evaluation of how dense the bones are and whether they're losing density over time. So they can check for osteopenia, they can check for osteoporosis, and the spectrum of bone loss in between.
One of the things I've noticed in looking at a lot of the people that have contacted us is the broad variety of skeletal injuries. People talking about injuries to their shoulder, broken fingers, broken femur, hip problems. It sounds like this is affecting the entire skeletal system, not just one part of the body.
Right. It's not just the arms or the legs. It's not just the big bones, the little bones as well. We've had clients who have reached for milk containers and snapped fingers. We've had clients who have fallen where in the ordinary course, you and I, in the 40s and 50s and 30s, regular middle-aged people who should fall and shouldn't be snapping bones. But this is occurring time and time again with some people, and then they find out that in fact, after getting a DEXA scan, that their bone mineral density is diminished, and it's something that they didn't know about and didn't know to check.
Some people end up hospitalized as a result of this drug?
Absolutely. Certainly for the kidney problems. If you're in full-blown kidney failure, you can be put in a hospital, you can be on dialysis, you can lose your kidneys, and we've had clients who regrettably have died from kidney failure.
Is there anything else that could be causing these injuries?
Really good question. HIV itself, the human immunodeficiency virus, can cause injury to kidneys and injuries to bone. And so there's a question, how do we know if it's the HIV that's causing the problem, or how do we know if it's the drug? Well, there are a number of ways that doctors can differentiate between the type of problem that's caused by HIV and type of problem caused by the drug. On a cellular level, looking under the microscope, you can actually tell a kidney cell that's been injured by HIV has a certain presentation, and a kidney kidney cell that's injured by tenofovir has a different presentation. So that's one answer. And another answer is something we were talking about before, is if you're on tenofovir, your kidneys should be doing fine. It suppresses HIV from replicating, so it shouldn't be injuring your kidneys.
Your kidneys should be improving because you're getting rid of the virus that was causing damage.
Exactly. So for certain people with certain baselines, you can tell pretty easily whether it's tenofovir-based or HIV-based. But yes, it's a good question. There are other antivirals that people with HIV take besides tenofovir that can cause these problems. And so the question of confounding agents is there and something that we have to look at seriously.
So when we are evaluating a case and helping prepare a case, we're looking at all the different medications somebody might be on to see whether any of those would be a possible cause for the damage as well.
Absolutely. And one of the things that we ask our clients to do is, if they can, get their printout from their pharmacy, from CVS or Walgreens or wherever, as quickly as they can. That will help us, one, identify which tenofovir-based drug they're on, and two, will help us learn what other antiviral drugs or whatever other type of drugs they're on, so we can help make a package. We can put a package together for our physicians to look at, to give us information as to whether they believe that the tenofovir played a role in causing a patient's harm.
Let's sort of switch topics a little bit and talk about the different drugs involved. I know there's 5 of them. We have Viree, Complera, Atripla, Truvada, and Stribild.
Right.
And so somebody could be on one of these drugs or been switched from one to another and from one to another to another. Does that have any effect on how we evaluate a case?
Scientifically, it's all tenofovir-based medication, so it makes it easy also from a legal standpoint, where all 5 of the drugs are made by the same manufacturer, Gilead. So we don't actually have much concern whether it's one of the 5 or a combination of the 5, if they're all Gilead-based drugs, tenofovir-based drugs that we believe should have been substituted for something safer.